Good morning, everybody. This is Captain Albright here to bring you another seminar presentation on neuromuscular blockers. I hope everyone is all settled in and enjoying their clinical sites and had a nice relaxing break. And with that being said, let's get started. So we all know that neuromuscular blockers are extremely important in anesthesia. Akinesia, or loss of movement, is a pillar in anesthesia. It can be accomplished by one of three ways: nerve block, large doses of potent inhaled anesthetics, and of course our neuromuscular blocking agents. Its purposes range anywhere from airway acquisition all the way to facilitating optimal surgical conditions for the surgeon. If not used properly, they can be extremely dangerous, and they are extremely important in anesthesia. So this is what we're going to be talking about today. And just so that everyone knows, all the information that is in this PowerPoint was obtained either through Barish or Morgan McHale to coincide with our test 1. And I threw a couple other tidbits in there for the boards and certification. Alright, so let's discuss the physiology of the neuromuscular junction. This process is one in which the somatic motor neuron sends a signal in the form of acetylcholine to the muscle cell, leading to depolarization and muscle contraction. So let's review this in some depth. It begins with a depolarization of the somatic motor neuron. This causes an action potential to travel along its membrane down its axon to its nerve button. This leads to the activation of voltage-gated calcium channels, influx of calcium, which causes a exocytosis of vesicles filled with acetylcholine to merge with the membrane and be exocytosed in the form of quanta. Acetylcholine exists in the neuromuscular junction, or this synaptic cleft, where it can do one of two things. It can be metabolized by acetylcholinesterase into acetate and choline, or it can bind to nicotinic cholinergic receptors. Nicotinic cholinergic receptors requires two acetylcholine molecules to be bound to its alpha subunits in order for a conformational change, which causes a pore to open in the protein, allowing sodium, potassium, and calcium to travel with their electrochemical gradients. If enough of these receptors are stimulated, the membrane potential will change from about -90 to -50, where an all or none threshold potential is reached, and an additional peritubular sodium channels are activated as well. This causes an even further depolarization of the membrane to a positive state. This depolarization will turn into an action potential that traverses the membrane all the way down its T-tubules with the assistance of these peritubular sodium receptors and channels. They propagate all the way down to the sarcoplasmic reticulum, where dihydropyrimidine receptors and ranitidine receptors undergo a conformational change, leading to a rapid increase in calcium levels of the muscle cell intracellularly, where troponin binds with calcium, and this allows the binding of actin and myosin and muscle contraction. It should be noted that the acetylcholine, after binding with those cholinergic nicotinic receptors, is a very short process in which acetylcholinesterase enzymes in the membrane will rapidly metabolize those acetylcholine molecules. So that long drawn out process is kind of important in understanding the mechanism of action for depolarizing and non-depolarizing drugs. We'll begin with the former. Succinylcholine is the only non-depolarizing competitive antagonist of nicotinic cholinergic receptors. So what it does is it causes a conformational change, resulting in continued depolarization, contrary to acetylcholine, which binds, is very quickly metabolized by acetylcholinesterase in the membrane. Succinylcholine is not. It has two acetylcholine receptor sites bound by an ester bond that connects it. It plugs into the nicotinic cholinergic receptor and doesn't let go, and cannot be metabolized. So there's a depolarization of the membrane. This causes action potential to go along the T-tubules causes the calcium release and initial muscle contraction, which is the fasciculations. However, you never have a repolarization because those sodium peritubular receptors, not the cholinergic receptors, those peritubular sodium channels cannot get out of this inactive state because it needs for the membrane to repolarize before it can enter that active state or off state to propagate another potential. So that's how succinylcholine works. Termination is only accomplished through passive diffusion of the succinylcholine molecule away from the receptor and into plasma, where it is metabolized by plasma cholinesterase, or otherwise known as pseudocholinesterase. Contrary to that, non-depolarizers are competitive antagonists of nicotinic cholinergic receptors. So they will bind to one of the two alpha receptor or alpha proteins of the receptor. And since the receptor needs both alpha proteins to be bonded to acetylcholine, one side blocks the other. So you never get activation of the receptor. So it binds in a competitive antagonistic fashion that does not cause depolarization. And termination is due to a diffusion away from the receptor in a competitive fashion with acetylcholine, and it redistributes to the plasma where it is metabolized and excreted by various means. Alright guys, so I thought it best to define some terms from Barish before we get started. So the first thing I'm going to talk about is ED95, and essentially what that is the estimated dose it takes to cause a 95% block of receptor sites in 50% of individuals. Now that's kind of clinically irrelevant. You only give clinical doses, which is usually the ED95 times 2. So for example, if the ED95 of rocuronium is 0.3 milligrams per kilogram, then the clinical dose, otherwise known as the estimated dose 95 times 2, would be 0.6 milligrams per kilogram, so double that. So for most of the typical doses you've memorized, that's the ED95 times 2 for the clinical dose. To discuss potency, it's important to note that certain drugs will have a lower milligram per kilogram dose to establish the same ED95 or ED95 times 2. They have equivalencies essentially. So if rocuronium's ED95 times 2 is 0.6 milligrams per kilogram and vecuronium is 0.1 milligrams per kilogram, that means that vecuronium is 6 times more potent than rocuronium. Okay, so for onset, this is inversely related to potency. So as I said, vecuronium is more potent than rocuronium. Rocuronium has a much quicker onset than vecuronium, 90 seconds versus 3 to 4 minutes. This is because a larger concentration is needed to reach the same potency. So what you have to do is you have a higher concentration of drug in the blood, which has a higher concentration gradient with the effector site of the neuromuscular junction. So that's why potency is inversely related to onset time. Another term we should talk about is duration of action. The time as defined by the book from the injection till 25% twitch height. Don't confuse this with 25% blocked. All this is saying is that if you got a standard baseline twitch height and then you gave the blocker at the time at which that's 25% of the original, that's when rapid reversal is possible, when you can give your anticholinesterase. Okay? How does that translate to us clinically? It translates at the time of train of 4 when you have 1 of 4 twitches. So when that first twitch comes back, you've reached that duration of action where you can give your rapid reversal. Alright, so I thought acetylcholinesterase or anticholinesterases. Okay, so let's describe phase 1 and phase 2 blockades. Phase 1 blockades, by definition, are a decreased twitch height with no fade in the following: train of 4, tetany, double burst stimulation, and post-tetanic potentiation. They are antagonized by non-depolarizing neuromuscular blockers such as defasciculating doses. So if you gave a defasciculating dose of rocuronium, then you're going to have to give more succinylcholine to have the same effect. They are also potentiated by cholinesterase inhibitors such as neostigmine. Phase 2 blocks can occur with succinylcholine depolarizing neuromuscular blockers greater than doses of 7 mg per kilogram or via continuous infusions. Or they can occur with non-depolarizing muscular blockade. They are classified as a positive fade in the train of 4, tetany, double burst stimulation, and post-atonic potentiation, and they are antagonized by cholinesterase inhibitors such as neostigmine. So let's talk about succinylcholine. It's an ultra-rapid depolarizing neuromuscular blocker. Of all the neuromuscular blockers, it provides the best conditions for intubation. Its onset of action is 60 to 90 seconds for the estimated 95 times 2 dose, which is the 0.6 milligrams per kilogram. At larger doses greater than 1 milligram, the onset of action is actually less than 60 seconds. It does cause histamine release, and it can cause cardiovascular side effects such as sinus brady, and that can lead all the way to asystole. That's attributed to succinylmonocholine, a metabolite, which is thought to agonize muscarinic receptors in the heart. Metabolism has already been discussed. The time to 25% recovery is 6 to 8 minutes. However, if you give 1 milligram per kilogram to the diaphragm starts contracting after 5 minutes. So that's clinically significant because if you've properly pre-oxygenated your patient and you haven't given a too large dose of your sedative hypnotic, and given that the duration of action of your sedative hypnotic is not longer, you could theoretically, in a cannot ventilate, cannot intubate scenario, regain ventilation 5 minutes in without the patient becoming hypoxic. So there are many side effects to succinylcholine. It is described as either you love it or you hate it. It's so good because its onset is so quick and its offset is so quick, but the side effects are significant. Fasciculations, myalgias, elevated intragastric pressure, with even greater increases in esophageal sphincter pressure, which is one of the reasons it's used for rapid sequence induction frequently. It can cause elevated intraocular and intracranial pressure. It can cause allergic reactions, trismus, also known as masseter muscle rigidity, hyperkalemia, even in patients that are not predisposed to it, 0.5 MEQs per liter for however many minutes its duration of action is. Contraindications include a history of malignant hyperthermia because it is a trigger for patients who are predisposed or who can trigger. Abnormal plasma cholinesterase because it will have a prolonged duration of action. Patients with renal failure, denervation injuries, spinal cord transections, stroke, trauma, burns, and the list goes on. Anything that causes an upregulation in extrajunctional acetylcholine receptors. So succinylcholine can cause bradycardia also in adults and in children. This can be mitigated by atropine or glycopyrrolate, an anticholinergic, typically adults on the second dose. It's cautioned for any pediatric use under the age of 12 because of undiagnosed myopathies, especially males. Kids have lower levels of pseudocholinesterase, which is the main source of metabolism for succinylcholine, till the age of 6 months. However, contrary to that, kids are typically more resistant to it, which is why there are higher doses. And that could be theorized because there's more junctional receptors or extrajunctional receptors, and there's more neuromuscular junctions per muscle fiber. As we age, all those neuromuscular junctions will consolidate to one junction per muscle fiber, one muscle unit. As you can see, the doses for children and infants, and if it is given IM, I thought it was significant to note that 4 milligrams per kilogram IM is equivalent to an onset of action of 4 minutes, which would take quite a bit of time, so 4 and 4. So non-depolarizing muscular blockers. So we all know there's aminosteroids and benzoyl and these are the ones that we're going to talk about. I have here noted that aminosteroids have a long elimination half-life. So rocuronium, vecuronium, and pancuronium, long elimination half-lives. However, rocuronium and vecuronium are considered intermediate acting, and this is because its termination of its action is by redistribution. And then with the benzoyl they have intermediate elimination half-lives of 20 to 25 minutes. Pancuronium is the only long-acting neuromuscular blocker. Down here on the screen I have the potency of the neuromuscular blockers from increasing to decreasing order. So cisatracurium is the most potent and rocuronium is the least potent. You can also know that this is the complete opposite spectrum of the onset of action. So if you look from the left to the right to the left, you have drugs that have the quickest onset with the drugs that have the slowest onset. This is why rocuronium is used in RSI as a supplement to succinylcholine. Alright, so doses, onset and duration. This is just a comparison chart of all the drugs that we're going to talk about here, so you can kind of see them lined up. As you can see, atracurium has a much higher ED95 times 2 dose than cisatracurium. Its onset is a little bit quicker, and its duration is comparable to cisatracurium. According to Barish, the metabolism and excretion of both of these drugs is through Hoffman elimination and ester hydrolysis. This is contrary to what I've heard before or seen in other sources. In other sources I've noted that only atracurium has ester hydrolysis while cisatracurium only has Hoffman elimination, and Barish counteracts that. Pancuronium has an onset of action of 2 to 4 minutes, and whenever you've given it at the 0.14 mg per kg dose, you've bought yourself 60 to 120 minutes of time until you have the availability of that 25% twitch that we had talked about, when you can reverse them. You can see here the various metabolism and excretion differences, and as you can see here, rocuronium, as stated, is the fastest onset, and its duration of action is pretty equivocal with vecuronium. This is why rocuronium has seemed to take precedent over vecuronium in many inductions. Atracurium. The benefits of this drug are its duration of action is so predictable even with disease states. So if you have a 90-year-old man compared to a 20-year-old female who's got no comorbidities, the duration of action is typically the same. Disadvantages is that it has such a slow onset, and if you try to counteract this by giving a larger dose, which you can do with most neuromuscular blockers, you have a massive histamine release. So anything greater than 0.5 mg per kilogram usually precipitates a large histamine release, which can cause hypotension, bronchospasm, and flushing. Lidonosine is a byproduct. It's epileptogenic in animals and studies, and has not been shown that in humans. This drug has fallen out of favor in the US since rocuronium has come to the forefront. Cisatracurium is an isomer, actually, of atracurium, so it's more potent with a lot less side effects. So you're having the same or an increase in potency, and this decreases the amount of drug that you actually have to give. So this mitigates the histamine release and also the lidonosine load. One interesting thing to note is that one randomized control trial, Papazian et al. In 2012, showed that patients who were on cisatracurium for paralysis had lower mortality than those on placebo. In addition, it should be noted that if you increase the dose to greater than 0.1 mg per kilogram to 0.15, you can increase the onset, the speed of onset, which is 3 to 5 minutes, but you bought yourself 60 minutes of duration. before you can reverse this. Pancuronium. No histamine release. It can counteract bradycardia effect of high opioid doses if that's what you're looking for. However, that can also be seen as a disadvantage with coronary artery disease, heart failure, previous MI, things that where you may not possibly want that. It's done in two ways. It increases the catecholamines available circulating, and it also causes vagal blockade. It's more difficult to reverse, and it's a higher incidence of weakness after surgery. So you're more worried about recurization. Vecuronium, it's virtually cardiovascularly neutral. Similar duration of action to rocuronium, however, it's not as fast on onset as rocuronium. Disadvantages are it has active metabolites, so if a patient has renal failure and you give them multiple doses or you do a drip, these can be accumulated and it can cause prolonged paralysis. Another disadvantage is that this vial you actually have to reconstitute, in contrast to rocuronium, which you do not. So rocuronium, lots of advantages. Its duration of action is comparable to VEC, but it has a shorter onset, as discussed. No metabolites. It's basically eliminated as the same drug either through the feces or the renal system or biliary system. So it doesn't require any type of metabolism. It's ED95 times 2. The standard dose is 0.6 mg per kg, and it has a 1.2 to 2 minute onset till maximum effect. One study, Andrews et al., 1999, showed that up to 77% of patients given 0.6 milligrams per kilogram had, at 60 seconds, with the equivalent of succinylcholine, good to excellent intubating conditions, and in many ways had the same intubation rate, successful intubation rate, as the succinylcholine group. So it shows that rocuronium is a suitable drug of choice when supplementing when succinylcholine is contraindicated for RSI. Disadvantages are that there are more allergic reactions when compared to other neuromuscular blocking agents. One survey, according to Barris, showed that of all the allergic reactions in the United States, neuromuscular blockers made up 11% of those. There's no histamine release, and there is slight hemodynamic changes, but this only happens if your dose exceeds ED95 times 4, which would be the 1.2 mg per kg. And that is known to be very minimal and much less than pancuronium. Let's discuss rocuronium with pediatrics. So in 2 to 12 years, much like succinylcholine, children require a higher dose. And to give you an example of that, RSIs with the doses of 1.2 mg per kg had an onset of 39 seconds in children, and the duration of action was only 41 minutes. Contrast that to adults, that dose would buy you the same duration of action as pancuronium of up to 60 to 100 minutes. So infants, rocuronium is more potent, so you'd want to decrease the dose in infants. Maintenance dosing is anywhere from 0.1 to 0.2 mg per kg, and that will buy you an added relaxation time of 10 to 20 minutes. And then I have provided the standard defasciculating dose for succinylcholine. Here's a list of drug interactions. I'm not going to read them to you. I don't think I have time to do that in this briefing, but if you can feel free at your leisure, go ahead and take a look the effects that they have on succinylcholine and non-depolarizing neuromuscular blockers. Similar chart, only I have active comorbidity disease states on the left and the response of succinylcholine and non-depolarizing neuromuscular blockers. Feel free to read this at your leisure. Usually depends on whether there's an upregulation of acetylcholine receptors or there is a loss. usually determines this. One thing I will note though, myotonia, which is something I didn't know before doing this briefing and something I've heard that pops up on boards, is that if you have myotonia and you give succinylcholine, you have sustained contractions. So, choice of muscles to monitor. It's important to note that blood flow plays a pivotal role because central acting muscles or central muscles receive more blood flow than peripheral muscles. So even though central muscles are more resistant, such as the diaphragm, the laryngeal adductors, they usually equilibrate quicker on the onset, even though they're more resistant because of blood flow. Now, that's why you monitor orbicularis oculi on intubation, and on extubation you monitor adductor pollicis, because there's a good chance that if adductor pollicis is recovered, then your diaphragm and your... Alright, so the way we monitor our patient's depth of blockade is through train of 4. Things that you should note is that if you have less than 2 to 3 twitches, then your patient is typically adequately relaxed. There is a chance that the diaphragm may start to depress again, undergo contractions, and it might mean that you need more opioids. It doesn't always mean you need more neuromuscular blockade. If you only have 1 twitch, it's still okay to redose your patient, but if you don't have any twitches, it's never appropriate to redose your patient with spot dosing. Endpoints I have here, you can always reverse when you have at least 1 twitch present, but however, you should be aware that the more twitches, the more effective and the quicker your reversal will be. And endpoints for extubation are sustained tetanus of 5 seconds and sustained head lift, which is affiliated with 50 to 60% blockade. So these are my thought-provoking questions for my discussion board group, and I will post these also in the forum. Congratulations, you guys have managed to sit through another seminar presentation. If you have any questions, you can direct them to the email address above. Hopefully you've learned something from this, and have a good day.